Hello, this is Dr. JoAnn Manson, professor of medicine at Harvard Medical School and Brigham and Women's Hospital. I'd like to talk with you about a recent report in JAMA Network Open on the subject of whether statin therapy may be able to offset some of the excess risk of venous thromboembolism, VTE, among women taking menopausal hormone therapy. Now, the authors leveraged an enormous administrative claims database to look at this question. And it's an important issue because we know that menopausal hormone therapy, especially oral therapy, is linked to an excess risk of VTE, approximately a doubling of risk in the randomized clinical trials. And also there's emerging evidence that statin therapy may be linked to a reduction in VTE risk, including from some randomized clinical trials such as the Jupiter trial. And this may be related to anti-inflammatory or antithrombotic effects of statin therapy. So the authors made use of a very large administrative claims database, Optum Health, looking at there were more than 15 million annual members, and they were able to identify 2,000 women with a diagnostic code for VTE and treatment for VTE. And the women were aged all between the ages of 50 and 64. And they compared them to controls without VTE, matched in 10-to-1 fashion with 200,000 controls, and then looked at these associations. Now, in this study among women taking menopausal hormone therapy, and about 50% were taking oral and about 50% non-oral, transdermal or other non-oral formulations of hormone therapy, the odds ratio for VTE was 1.53 among the women who did not also have in the database prescription records for statin therapy. They were able to look at prescriptions for both the hormone therapy and the statins. And so it was 1.53 among the women who weren't also taking statins. And then among the women prescribed hormone therapy and also low to intermediate dose statins, the odds ratio was 1.29. So that was quite a mitigation of that elevated risk. And among the women taking high intensity statins, the odds ratio was 1.06, and there was no significant elevation. So we do need more data and more research on this question. One approach would be a meta-analysis of all of the existing randomized trials of hormone therapy in recent years where there's increased uptake of statin therapy, to look at this question not only for VTE, but also for coronary heart disease and stroke and other CVD outcomes, and see if statin therapy is associated with some attenuation of the excess risk, and also a targeted randomized trial of statins versus a placebo among women who are clearly candidates, have clear indications for hormone therapy that may be at some increased risk of VTE. That type of trial would be extremely helpful. But in the interim, there are ways to minimize risk of VTE among women who are clear candidates for menopausal hormone therapy, and that includes, especially among women at increased risk of VTE, choosing a transdermal rather than an oral formulation of hormone therapy and using lower doses of hormone therapy. Also, women who are clear candidates for hormone therapy and also clear candidates for statins. It's obvious that statins could be co-prescribed, but even among women who are clear candidates for hormone therapy, but only intermediate, borderline candidates for statin therapy, the prescription of statins might be considered in that clinical scenario in order to try to mitigate that excess risk. Thank you so much for your attention. This is JoAnn Manson.